Thank you so much, Dean Daly, for those very inspiring comments. I have the pleasure now of introducing our keynote speaker for this morning, Dr. Rhonda Sealey-Thomas. Dr. Sealey-Thomas is Assistant Director of the Pan American Health Organization, PAHO. She is a medical doctor, has a master's degree in public health and a doctorate in public health from the University of the West Indies. She's held numerous leadership positions in the health sector. Prior to her appointment at PAHO, Dr. Sealey-Thomas was Chief Medical Officer for the Ministry of Health in Antigua and Barbuda and was the Chief Technical Advisor to the Minister of Health on all public health matters of regional and international concern. Welcome, Dr. Sealey-Thomas. Thank you so much for being here. We're looking forward to your comments.
Thank you, Louise. Dr. George Daly, Dean of Harvard Medical School, Dr. Louise Ivers, Director, Harvard Global Health Institute, distinguished guests, esteemed colleagues, students, and dedicated champions of global health, good morning, and thank you for allowing me to address you. It is both an honor and a privilege for me to address such a distinguished gathering of individuals committed to advancing health equity. Today, as we gather at this vital crossroad of science, policy, and human rights, we must ask ourselves, are we truly delivering on the promise of health equity? Or are we merely inching forward while millions continue to be left behind? Health equity is a fundamental component of social justice that indicates the absence of avoidable, unfair, and remediable differences in health outcomes among groups of people due to their social, economic, demographic, or geographic circumstances. It denotes that everyone should have the opportunity to obtain the highest level of health. As public health professionals, we should see health equity not merely as an aspiration, but as our obligation working towards ensuring that every person, regardless of where they live, their socioeconomic status, age, race, ethnicity, gender, or disability, has an equal opportunity to achieve their highest standard of health. Despite remarkable advancements in health policy, medical breakthroughs, and technological innovations over the past decades, including the development of new vaccines, medicines, and AI applications in healthcare, vast health disparities persist. For example, a child born in the region of the Americas where I am from, particularly in Latin America and the Caribbean today, there is still significantly more likely to die before his or her fifth birthday than a child born in Norway. Moreover, the maternal mortality ratio in the region of the Americas is over 5 times higher than that in Europe. These differences in health outcomes are a stark reminder that we have not yet fulfilled the promise of health equity in the region of the Americas. So why is it that despite global resources and innovation, the health equity gap persists? Answers lie in structural inequities in wealth distribution, systemic discrimination, and underinvestment in primary healthcare systems. The fragmentation of global health governance and the commercialization of health delivery have only exacerbated these challenges. Latin America and the Caribbean is the most inequitable region in the world. The health inequities that plague this region and prevent us from moving towards more just, inclusive, and productive societies are inextricably linked to deeply entrenched inequities in other dimensions, such as income inequality, unequal access to quality education, decent work, and social protection and adequate housing. The wealthiest 10% of the population in Latin America and the Caribbean earn 12 times more than the poorest 10%, a contrast to the ratio of 4 in developed countries of the Organization for Economic Cooperation and Development. Between 1990 and 2014, the region of the Americas experienced a reduction in income inequality. However, progress since then has stalled, in part due to the serious economic impacts that resulted from the COVID-19 pandemic. The intergenerational transmission of inequity is particularly worrying. Being born in a low-income neighborhood, belonging to an ethnic or racial minority group, and having parents with limited schooling or low-paying occupations all contribute to trapping future generations in cycles of poverty in our region. These cycles of poverty, inequality, and inequity, and a lack of social mobility directly influence health outcomes in the region and prevent many from accessing the resources they need to lead healthy lives. The COVID-19 pandemic further exposed these long-standing inequalities and inequities. The region of the Americas was particularly affected by the pandemic, accounting for 25% of all cases and 43% of all deaths, making it the region with the highest number of COVID-19 deaths worldwide. Structural inequalities such as high levels of labor informality, weak social protection systems, and fragmented health systems all contributed to this crisis and illuminated the urgent need to address inequities with meaningful, long-term solutions. Permit me to highlight a few examples in the region of the Americas where health inequities exist and how PAHO, Pan American Health Organization, is working to eliminate them. As a background, PAHO is a specialized international public health agency dedicated to improving health and well-being across the Americas. Established in 1902, PAHO has a dual role. Firstly, it is a specialized agency of the Inter-American System, and it also serves as the regional office of the World Health Organization, or WHO. While PAHO forms part of the UN system and Inter-American systems, it is important to highlight, particularly at this time, that it retains a special, unique, and separate legal personality and decision-making authority from both. In its origins, PAHO reported on sanitary conditions in seaports, maritime quarantines, and the control of infectious diseases. In 1920, it expanded this role to health promotion. Today, PAHO is involved in supporting countries in the prevention, control, and treatment of a wide range of health issues, including non-communicable diseases, including cancer, demonstrating the organization's ability to transition and adapt to a changing health landscape. And I'm sure you'll agree with me that that's a skill that we need to dig deep and strengthen given the changing political and global landscape. PAHO's work has also focused on improving the quality of life in countries of the region and underscoring the clear link between health, social and economic development and political stability. I'd like to highlight 4 key areas where health inequities exist in the region and illustrate how PAHO is actively working to address them. Firstly, regarding maternal mortality, approximately 7,800 maternal deaths occur each year in the region of the Americas, equivalent to almost 1 maternal death every hour. While there was a reduction in the maternal mortality ratio between 2000 and 2023, the region had the smallest percentage reduction in MMR in any world region during this time period. The inequity that is faced in our region with regard to maternal mortality is further illustrated by the fact that women living in rural areas and poorer communities, those with lower levels of education, and younger adolescents, those 10 to 14 years of age, face a higher risk of complications and death as a result of pregnancy. The leading causes of maternal mortality in the region are high blood pressure and hemorrhage, which can be prevented, detected, and managed adequately given the advances in medical technologies and diagnosis. Most maternal deaths that occur in our region are preventable through improved access to quality health care, contraception, and reduced inequities linked to cultural differences, poverty, and a lack of good education systems. In response to the increasing maternal mortality rates in the America, PAHO has launched a strategy for accelerating maternal mortality reduction in the region based on primary health care. In June of 2024, it focused on improving access to quality care, reducing inequities, and addressing the underlying social determinants of health. It emphasizes expanding and strengthening primary health care, prioritizing territories and population groups most at risk of experiencing maternal mortality, intercultural care, and intersectoral collaboration to ensure the health and well-being of women across their life course. Cervical cancer is a second condition that exposes these health inequities in our region. Although it is preventable and curable if detected early, it remains one of the leading causes of cancer-related deaths among women in low and middle-income countries. This is particularly concerning, since despite having the tools available to prevent, detect, and treat, and eventually eliminate cervical cancer as a public health problem in Latin America and the Caribbean, mortality rates are 3 times higher than in North America. Disparities also exist within countries, particularly among indigenous women who face structural, social, and cultural barriers to access HPV vaccination, screening, and treatment. PAHO is supporting efforts to eliminate cervical cancer through comprehensive strategies, providing assistance in developing national cervical cancer elimination plans in countries of the Americas, supporting the implementation and scaling up of programs such as single-dose vaccination schemes and the use of human papillomavirus testing as the main cervical cancer screening method through our regional revolving funds, a mechanism that allows our countries in the region to pool their resources to access HPV vaccines, HPV tests, and equipment for treatment of precancerous lesions at a low cost. Through this mechanism, we endeavor to bridge the equity gap in cervical cancer and ensure that all women, regardless of age, place of residence, ethnicity, or socioeconomic status, have access to cervical cancer prevention, detection, and screening technologies while recognizing the critical role of culturally sensitive education and outreach, community engagement, and empowerment strategies for women and girls in situations of vulnerability. Thirdly, in Latin America and the Caribbean, over 29,000 children and adolescents are diagnosed with cancer annually, with 10,000 dying, representing the second leading cause of death in this age group. While over 80% of children with cancer in high-income countries survive, in our region, only 20% in low and middle-income countries survive. Due to a lack of diagnosis, misdiagnosis or delayed diagnosis, obstacles to accessing care, abandonment of treatment, death from toxicity, and higher rates of relapse. In partnership with St. Jude's Research Hospital and Ministries of Health across the region, PAHO is working to address this gap. Through the Global Initiative for Childhood Cancer, we are supporting countries to develop national childhood cancer plans, improving access to care, ensuring the availability of essential medicines, and strengthening pediatric oncology training. A technical package called Cure All is guiding the development of these national childhood cancer plans and interventions. Activities include supporting clinical care for the most vulnerable children, ensuring that all children with cancer have access to high-quality medicines and technologies, strengthening training programs through the development of centers of excellence, and supporting the development of care coverage regulations and treatment and monitoring tools. The PAHO revolving funds once again contributes to this endeavor by ensuring the availability of essential medicines. By 2030, we aim to achieve a survival rate of at least 60% for 6 of the most common types of childhood cancers in low and middle income countries in our region. The fourth and final area I'd like to highlight is the situation with neglected tropical diseases, or NTDs, which disproportionately affect populations in situations of vulnerability, exacerbating existing health, gender, and socioeconomic inequities. During the last decade, PAHO has been actively working to eliminate NTDs in the Americas through initiatives that focus on addressing health inequities by bringing prevention, diagnosis, and treatment closer to communities, especially those that are most marginalized, including indigenous and those in remote areas in the Americas. One of the priorities of our disease elimination initiative that aims to eliminate over 30 communicable diseases, including NTDs, and related conditions in the region by 2030. The initiative promotes an integrated, sustainable approach to accelerate progress, leveraging technical cooperation, research, training, and the donation of medicines and diagnostic tools to those in need. With the technical support of PAHO, the Americas has achieved significant milestones during the last decade in NTDs, including the elimination of onchocerciasis in Colombia, Ecuador, Guatemala, and Mexico, and more recently in 2024, the elimination of lymphatic filariasis in Brazil. In addition, PAHO has been working towards the elimination of trachoma, a leading cause of blindness in countries such as Brazil and Guatemala. By focusing on health equity and leveraging innovative strategies, PAHO is making strides towards a future free from neglected tropical diseases in our region. Ladies and gentlemen, the future of global health is not written in stone. It is shaped by the choices we make today. Even in the face of substantial challenges, we must uphold the values of equity and health as a human right. All pregnant women deserve the right to a safe pregnancy, delivery, and postpartum care in a setting that is suitable to their cultural and other unique needs. The children that they bear deserve the right to survive. Economic, geographic, and political barriers to treatment options should not hamper their survival from diseases such as cancer, trachoma, and other neglected tropical diseases that can be detected early, treated effectively, and in many instances cured. Delivering on the promise of health equity can be realized if we act with intentionality in three critical areas. Firstly, strengthening primary healthcare systems. By investing in community-led solutions, bolstering health infrastructures, and prioritizing preventive care and health promotion, for example, for cervical cancer, we can create sustainable change. Secondly, promoting equitable innovation and technology. The advancements in artificial intelligence, telemedicine, and vaccines and new medicine development must be deployed inclusively, rather access for all, not deepening existing divides. Thirdly, addressing the social determinants of health, improving education, income inequality, housing, employment opportunities, and access to social protection are essential to reducing health disparities in the Americas. As Dean Daly said this morning in his remarks, we must think creatively and collaboratively to address health inequity in the region. As we gather today and as we leave this symposium, let us move beyond the rhetoric and towards action. Let us challenge outdated models, build alliances to achieve common goals, and continue to work to deliver the promise of health equity into a reality for all. Thank you for your attention.